Today we're going to be looking at gigantism and acromegaly, two conditions which involve excess growth hormone in the blood. Before looking at these conditions in more detail, it's important to understand the somatotropic axis. We start off with the hypothalamus, which secretes a substance known as GHRH, or growth hormone releasing hormone, which acts on the anterior pituitary gland to trigger the release of growth hormone, or GH. This GH then stimulates the liver and other tissues to produce insulin growth factor 1, or IGF-1, and it's this IGF-1 which has the effects of bone development, muscle growth, and metabolism. It's important to note that this whole process is governed by a negative feedback loop, so as the levels of IGF-1 increase, the levels of GH and GHRH should decrease respectively. And another point to mention is that the hypothalamus produces a substance called somatostatin, which has an inhibitory effect on the anterior pituitary gland to reduce the levels of GH produced by it. Okay, so acromegaly and gigantism both involve excess levels of growth hormone in the blood. And there can be different causes for this. For example, a pituitary tumor, which causes the anterior pituitary gland to release more GH, and then IGF-1 values go up respectively as well. And it's important to note that this tumor is most usually a benign pituitary adenoma. There can be other causes as well which are a bit rarer, such as non-pituitary tumors in the pancreas or lungs, which directly increase the levels of GH via an ectopic source. But the pituitary tumors are the most common cause. Taking a look at the signs and symptoms of acromegaly and gigantism, a key distinction to make is that acromegaly involves excess growth hormone after fusion of the epiphyses of bones, while gigantism involves excess growth hormone before the fusion of the epiphyses. And it's important to make this distinction as it affects the symptoms experienced by both conditions. If we take a look at acromegaly first, possible signs and symptoms include large hands and feet, prominent facial features, skin changes and excess sweating, as well as a couple of more symptoms which are related in particular to pituitary adenomas, such as recurrent headaches and visual changes, which could be a bitemporal hemianopia. If we take a look at gigantism, the symptoms are in fact very similar, but a key difference is tall stature, as you can see from this photograph here. And the reason for this tall stature is that there was excess growth hormone before the fusion of the epiphyses, so the long bones extend beyond normal limits, and this results in increased height. If you're suspecting a diagnosis of acromegaly or gigantism, aside from the clinical features, it's important to conduct some investigations, such as a serum IGF-1 and serum growth hormone level. And this can be a useful screening tool where high levels of these substances can be indicative of the condition. To actually confirm the diagnosis, an oral glucose tolerance test should be performed, where oral glucose is administered and the effect on growth hormone is measured, and I'll explain this in more detail in the next slide. It's also important to consider some imaging, such as an MRI of the pituitary glands to look for a pituitary adenoma, or a CT chest abdo-pelvis to look for an ectopic GH source if the pituitary adenoma is not found. And here we just have an image of an MRI of the pituitary gland, and you can see a macroadenoma present which led to acromegaly symptoms in this patient. Okay, just to go over the oral glucose tolerance test. The process involves administering 75 grams of oral glucose to the patient and measuring the growth hormone and IGF-1 values regularly over 2 hours at roughly 30-minute intervals. And to explain this in more detail, we have our normal axis here, and when we administer glucose, it should theoretically reduce the levels of growth hormone, and consequently the levels of IGF-1 also go down. This is a normal result. If we compare this to the gigantism and acromegaly axis, here you can see that there's a problem with the anterior pituitary gland. There's a pituitary adenoma present, and there's more growth hormone than normal being produced. So when we administer glucose in this case, the growth hormone levels do go down slightly, and IGF-1 also goes down a bit, but they remain high compared with normal values. And if this is the case, it's important to perform an MRI of the pituitary gland to look for a pituitary adenoma which might be present. In terms of the management of these conditions, we can start off by looking at medical options, such as the use of somatostatin analogues like octreotide and lanreotide. And the way these medications work is that if you remember the top part of our axis, the hypothalamus can produce a substance called somatostatin, which inhibits growth hormone release. So if you replace this with a somatostatin analog, this can help to theoretically reduce the levels of growth hormone in the blood. In terms of definitive management, surgery is an option, with transphenol surgery being the most common performed to remove a pituitary adenoma present. This can be followed up with radiotherapy if indicated. In the cases of ectopic GH sources, it's important to treat the underlying cause, whether that be with chemotherapy or surgery. Okay, just to finish off, we have a quick clinical case here. A 38-year-old male presents with headaches and coarsening of facial features. He complains that his wedding ring no longer fits and he's had to buy larger shoes. On examination, he appears to have a protruding jaw and oily skin. What is the most likely diagnosis in this case? Well, based on this patient's presentation, you can probably tell that there's a large amount of growth hormone in the blood. And to distinguish between gigantism and acromegaly, you can see that the patient does not have a tall stature and is presented quite late. So based on this, the most likely diagnosis would be acromegaly. As a follow-up question, the patient is referred for the oral glucose tolerance test. What do these results suggest? So from this table, you can see that the values of growth hormone and IGF-1 did not change significantly after giving oral glucose. So based on this is most likely to be caused by a pituitary adenoma, and a pituitary MRI should be performed to confirm this. And here we have a quick summary slide explaining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next video.